When you hear the word Ebola, what other words come to mind? Safety, security, transmission, quarantine. You need to stay tuned for Health Watch. Coming up next. Hello, I'm Terrence Zachary Anderson, and this is Health Watch. So, do you feel comfortable with your knowledge of Ebola? Do you know how it is transmitted, where it comes from, the current status of the disease in America? Do you know what local health departments, hospitals, and emergency preparedness agencies are doing to protect you and your family? We're going to address those questions on today's edition of Health Watch, and I brought on board a trio of professionals who will help us navigate through some of the uncertainties you may have. It is my great pleasure to introduce you to Dr. Demetria Lindsay, Director of the Norfolk Department of Public Health, Jim Reddick, the Director of the City of Norfolk's Department of Emergency Preparedness and Response, and Kevin Boucher, Infection Preventionist, Centera Lee. Welcome to Health Watch, guys.
Thanks, Terrence.
Dr. Lindsay, in doing research for the show, I learned that Ebola is named for a river. It was discovered in 1976 and named for a river, the Ebola River in the Democratic Republic of Congo. But what is Ebola?
Ebola is a communicable disease that is caused by a virus. In the past, we've seen periodic outbreaks in sporadic areas, usually in rural parts of Africa. However, what we're seeing now in the western part of Africa in terms of the extent of the outbreak is something that's unprecedented, that we've not seen before.
And to address any fears that anyone might have, are there or have there been any cases of Ebola in Virginia?
There have not been any cases in Virginia, no.
And what are the signs and symptoms of Ebola?
Generally, a person may, at the beginning of the infection, have fever, fatigue, muscle aches, vomiting, diarrhea, stomach aches. They may also have unexplained bruising as well.
How soon after exposure do the symptoms tend to develop?
Symptoms can occur anywhere from 2 days to 21 days, but generally it's within about 8 to 10 days after exposure.
Who is at the greatest risk of contracting Ebola?
The individuals that would be at greatest risk would be individuals who are from those countries that we're seeing infections in now. The major ones being Sierra Leone, Guinea, and Liberia. Recently, Mali was also added, but the cases there are much smaller in number than the other countries that I mentioned. And those would be individuals who have had some direct or close contact with someone who is ill with the disease. Also, health workers are at significantly higher risk than the general population, and individuals who may have handled bodies of deceased who died from an Ebola infection. And in Africa in particular, people who may eat or handle certain types of animals such as primates or fruit bats.
Primates or fruit bats, interesting.
Right. So that would be eating bushmeat.
Right. How is it to be determined that someone in the U.S. has Ebola?
Well, first of all, it's not an infection that we would typically expect to see in this country. So one of the major things that a healthcare worker would do in terms of trying to determine if someone had the infection would be to take a good history. And a history of travel within the last 21 days to one of those countries where we're seeing infection, or particularly if there has been contact with someone who's had an Ebola infection, or handling of a body of someone who's been deceased, or eating bushmeat, in terms of identifying risk factors for the disease. If the healthcare worker then determines that someone has a risk for the infection, then they may at that point go on to request testing, and testing is done with a blood test. That does require approval from the health department, and we facilitate getting the test done. We have a state laboratory in Virginia that is a designated lab to perform preliminary blood testing for Ebola. However, the final confirmatory test is done at the CDC in Atlanta.
Can you talk a little bit more about how it is spread? You mentioned a couple of ways, but can you elaborate?
Well, basically, the major route of spread would be some form of contact with bodily fluids. And that could be any bodily fluids of a person who's infected, so such as blood, semen, if this person has vomited or has diarrhea. Generally, those fluids are going to be most infectious when someone is very ill with the infection. So hence, that is why healthcare workers are at much higher risk than the general population. But also bodies are also infectious. So in Africa, where culturally it's common to take care of the bodies of deceased in the family and friends, that poses an additional risk to that population.
They're incinerating bodies over there. They're cremating them, or
yes, and that would also be the recommended approach here if someone died of Ebola, would be to cremate the body rather than go through the normal burial procedure.
Now, you mentioned bushmeat, primates, and insects, fruit bats, rather. But what about people's pets? And can Ebola be spread through insects?
No, it cannot be spread through insects.
Okay.
And one would not, there's not been any evidence of exposure to the disease through domestic animals such as dogs or cats. There has been some evidence that dogs may be able to acquire the infection, but no evidence that they become ill or able to transmit the infection to someone else.
What if you were to come into contact with someone that has Ebola but doesn't have symptoms? Can it be spread then?
No. If an individual is healthy and has may have come in contact with someone but is healthy themselves, are not ill from the infection, then or is not infected, has no evidence of infection such as the symptoms that we talked about, they are not able to spread the disease.
I see. Jim, I recently attended an event that you staged, an Ebola event that you staged at Norfolk State University, and there were a number of different agencies there, a number of different agencies that tend to partner with one another. Sure. You refer to them as Team Norfolk.
Correct.
What is Team Norfolk, and what is Team Norfolk doing for surveillance and to protect the citizens of Norfolk? What kind of steps are being taken?
Sure. Well, Team Norfolk is our approach to addressing all hazards, whether it be natural and man-made, technical. We're all in the same community together, so our approach is that we're all going to leverage the resources that we have, share information that we have, work together in terms of planning, training, and exercises, so we all address it in a more efficient and effective manner. So Team Norfolk consists of public, private, not-for-profit, higher education, and military. Again, all of us, one team, one fight approach. So the same group that we're going to work with for hurricanes and winter storms are the same group we're going to work with for an Ebola response. And as we continue to do these training and exercises, we get more and more folks and more agencies involved with Team Norfolk. So then again, it continues to be more comprehensive and more effective. So the exercise that we did on Friday was to really, again, take an opportunity to identify what resources and expertise we have in the community from the various sectors and levels of government. How do we bring it all together to paint that common operational picture, and otherwise just hear what everyone else is doing and raise that awareness of the threat from Dr. Lindsay, but also how we're going to drive forward together as one.
I was very impressed by the number of different agencies that were at the table. Literally at the tables, there were so many folks. Can you name some of the agencies, some of the partner agencies?
Oh, sure. I mean, the schools and higher education were at the table. Coast Guard and the Navy were at the table. Not-for-profits, like the Red Cross, Operation Blessing. Operation Blessing actually had one of the presenters at that meeting who was self-quarantined coming back from Liberia, coming in through Skype. So he was able to provide some boots-on-the-ground observations. So again, we can take the lessons learned that they have, an international agency in our own backyard, providing some information for our planning. So we had a lot of folks at the table, and I hope that your viewers can see that we have a lot of folks that come to the table, and Team Norfolk is all-inclusive, and all of us are part of Team Norfolk, from the individual homeowner to the government, to the military, to everyone else. Our job is to share plans and make sure that we're all on the same page.
We are formerly now called Hampton Roads. Some people might want to call us Coastal Virginia in the not too distant future, but we were formerly known as Tidewater, and that's because there's water everywhere.
Sure.
There are a lot of ports in this area. There are a lot of ports in Norfolk. If someone were to come in from one of these affected countries by sea, who is responsible to keep us safe?
Our partners at the Coast Guard. They monitor the ships that are coming in, not only reaching out to them, but identifying their previous protocols, their previous visits to other countries. They're also tracking on any changes to their crew, and otherwise identifying any sicknesses that they have on board, and if needed, they'll set them aside for quarantine. But the Coast Guard is the lead on all ships, vessels, and cruise ships coming into the area.
And they had a good contingency of people at the meeting.
Oh, yes, they did. Yes, they did.
And what about the airports? What are airports doing?
Well, as mentioned earlier, there's about 5 or 6 airports throughout the nation that have protocols for receiving folks in from those international flights from West Africa. Norfolk International Airport has a contingency plan if they had to be rerouted into Norfolk, in which case, again, plans are in place to work with Dr. Lindsay's shop, the CDC, the Customs and Border Protection, to ensure that the folks receive the care that they need, and otherwise isolating them from general population.
Just following up on Jim's comment there, what would happen, Dr. Lindsay, if someone were to come in from an airport who we feel was symptomatic or at risk for Ebola?
Well, if someone came into one of the major airports that have been identified for over 90% of people coming from those countries, and initially, as Jim mentioned, they would be evaluated by U.S. Customs and the CDC quarantine station. If a public health officer identified a traveler from one of those countries who has symptoms that may be suggestive of Ebola, their travel would be discontinued at that point, and they would be immediately transferred safely to a selected hospital in the immediate area of the airport. If the traveler has a history of travel to an affected country, however, they have no symptoms and are therefore not infectious or able to pass on infection, then they would be referred on to the local health department to monitor them for 21 days to ensure that they did not later develop symptoms of infection.
Okay.
That's what I meant to say.
Well, you were giving two different angles on that, two different perspectives.
I might add that if someone is considered very high risk, but at that point is not infectious, then although they may be able to travel on to their final destination, they would not be permitted to use public transportation, and that would have to be very closely coordinated with the health department to ensure the safety of the public in their travels.
We play a major role in all of this. Jim, the city runs the 911 system.
Right.
What would happen? Can you give us a scenario of what would happen if someone with Ebola calls 911?
Sure. We've implemented, in partnership with Norfolk Fire Rescue, emergency medical dispatch protocols where if folks are calling and they're indicating signs or symptoms of Ebola, then there's a whole nother script that they're going to read from asking specific questions. And if it calls for it in the dispatch to Norfolk Fire Rescue folks, they're going to be forewarned, if you will, of any potential cases of Ebola at the residence that they're going to be responding to, which may require them to don certain personal protective equipment in order to protect themselves. So it's really just a warning to the dispatchers, a warning to the fire rescue responders, and also letting the folks know that folks may be coming in equipment, personal protective equipment to their house, not to be afraid, but it's just following certain protocols to make sure that everybody's safe every step along the way.
Kevin, I want to ask you about PPE, personal protective equipment, in just a second here, but what are the hospitals doing in general to prepare for Ebola?
Well, we have a multi-pronged approach. We're looking at all of our, what we call gateways, so the entrances where people would be seen, and we screen them all at that point. There's two basic things that you would screen for is travel to West Africa and either exposure to someone with Ebola or symptoms. And we screen all of our patients through those. And we have set up systems of compartmentalization and containment from each point. So going from a doctor's office, if you said you were from West Africa and had a fever 101, at that point they would be able to have a process to take you and safely remove you and get you into a hospital where you could be seen and treated without exposing people. If you're going directly to the hospital, you'd be going from that triage area, the ER or any of the gateways, to progressive containment, from isolation room to the CDC has designated 3 specific hospitals to transfer to if it's available. And yet, within Sentara, we've created 2 hospitals, Princess Anne and Williamsburg. We have created, from our observation areas, 2 containment rooms that would be electronically monitored and provide enough personal protective equipment and such so that you could take care of those patients safely without any exposure to either our staff or other patients.
Now, how would those patients be taken care of? I mean, you mentioned treatment. What would be done? Is there medicine that can be given?
Actually, there is some questionable antiviral medications that are out there, but right now, mostly it is supportive care. They start to lose volumes and volumes of fluid, and that has to be replaced. IVs, fluid, and such. They have massive diarrhea on day 12, like 8 to 10 liters of fluid. That's an awful lot that has to be replaced. And with that goes your electrolytes, so you have to monitor that and replace. So it is more of a supportive therapy to make sure that they can get through their battle.
With that type of fluid loss in a hospital environment, and you have hospital care workers taking care of these patients, tell us a little bit, just a bit about PPE, personal protective equipment.
Great. We have within our area set up different levels. So we have 5 levels. So the person who is seeing you at the front desk and you say you have Ebola, that registration person will put a mask on herself, would put gloves on, hand the patient a mask, keep herself from touching the patient at that point, and call in the next level. And the next level would be fully gowned, gloved, masked, that no skin would be involved, and then be able to take that patient and move them into an isolation room. An isolation room has got a negative connotation, but it's protecting the patient from all other outside influences, so that it's a controlled environment that we have. And then we have a series of anti-rooms and negative air flows so that everything is purified and maintained and controlled. Even the waste is controlled. And with the waste, we have made sure that all these rooms have the ability to have toilets and IVs and everything that you would need to either replenish the fluids or help with the elimination of the fluids.
Let me ask you a question. If a hospital is caring for someone that has in fact been diagnosed with Ebola, is it safe for others to come to the hospital?
Yeah, if you looked at what we were doing and you were to take the entirety of the hospital, and with these isolation rooms, this is one person and the staff are removed, contained, and not interjected into any other of that populace. No matter how much you wanted to try, you could not get involved in that. Somebody coming in for an x-ray, somebody going for surgery, somebody going for a hip replacement, will never come in contact with either the patient, anything that would have been exposed to that patient, any equipment that would have been used with that patient, anything at all. So there is no potential for cross transmission. That is our goal, is that no staff and no patient gets exposed.
Dr. Lindsay, Kevin made a reference to isolation, but the health department is responsible for quarantine, is it not?
Correct.
And what is the difference?
Isolation is really the separation of someone who is ill in some physical manner to prevent transmission of infection to others. Quarantine involves separation of individuals who are healthy. They may have the potential for developing infection, but at that point they are healthy and have no symptoms of infection. So when we talk about quarantine, we get into issues of really confining individuals or limiting their freedom, so we have certain rights that we have to observe for that.
And how is isolation and quarantine enforced? What is the enforcement like for that?
Generally in public health, when we quarantine an individual who is healthy but we have concerns that they may pose a risk of infection, the preferable approach would be voluntary quarantine. So it's very important to establish a good rapport with the patient and the family to ensure that all of their basic needs are taken care of, and to limit them in the least restrictive fashion possible. In this case, we monitor people, would be monitoring people twice a day, ensuring that they're checking their temperature and evaluating whether or not they have symptoms for Ebola. However, if there is evidence or under that process that the individual is not complying with voluntary quarantine, or we have significant concerns, then we can move on to involuntary quarantine. And the Code of Virginia allows this through the State Health Commissioner. She is the only one in the state who has that authority to involuntarily quarantine someone.
I see. I want to make sure that we get another question or two in before we run out of time here, but I also want to make sure that we give your contact information. If someone has questions, Kevin, how can they reach Centerra-Lee?
Phone call,
just reach out to you?
261-6936 is the infection control office, and we available answer whatever we can.
And you are an infection preventionist.
Correct.
I like that. That's a cool name.
We got rid of control because we have no control. We now are focused on prevention.
I see. And Jim, what about the city of Norfolk?
Sure. The Office of Emergency Preparedness and Response phone number is 441-5600. And you can also see our information at norfolk.gov, which, if we're doing it right, you're going to see the same information on Kevin's website and Dr. Lindsay's website as well.
And Dr. Lindsay, where can we refer folks?
We have one number that anyone in the state can call, and that's 1-877-ASK-VDH3.
And that's an easy one to remember, ASK-VDH3. And I think we also have a CDC website that we're putting up on the screen as well. Dr. Lindsay, we talked a bit about the fact that there is no treatment presently for Ebola. But are there vaccines being developed?
There's not currently a vaccine available, but yes, there are some that are under development. So we hope that with trials coming up or underway currently, that we'll have something in the future.
And I would like to give each of you an opportunity to add anything else that you might want to cover. Anything at all that you wanted to discuss?
Well, speaking of the vaccines, the serum of the survivors seems to have some good effect, and they're looking into that. Hopefully they'll come up with that it would be a treatment, not necessarily a vaccination, but that's been used a couple of times so far and has been successful. We're hoping it will bring about more.
I'll just say that from the emergency management perspective, the fact that we're using the incident command system to respond to this incident, there's information sharing all throughout the various agencies. So there's really no silos of excellence anymore. We've been able to break those down, bring our partners to the table to make sure that we're leveraging all the resources that we have in the community and the expertise. So it's not just a government response. It's the Team Norfolk, the whole community response.
Right. And again, that was a very, very impressive thing that I saw there.
Thank you.
And I've been at the EOC when there have been natural emergencies, storm and so forth. Dr. Lindsay, you want to add anything at all?
I think what Jim has said in terms of the preparedness of the community or the city leadership for an infection like this is very important. We do work very well together, and we are prepared to respond. Even though this is a very scary infection, it probably is also important that people put it in perspective. The risk is very low in our community and even in the United States. It's much more likely that with the symptoms that I described, an individual in the U.S. will have the flu, and even someone coming from those West African countries may be more likely to have malaria than actually having Ebola. But we have put a lot of things in place to ensure that we can keep the public safe.
Well, guys, I want to thank you all for coming on to show a cohesive front as we face Ebola. We've given out a lot of good information, and I'm sure that we're going to get some inquiries. Thank you again so very much. Appreciate you coming on board.
Thank you very much.
And we want to thank you for joining us for this edition of Health Watch. Remember, if you have any questions, you can give me a call at 757-683-8836. Again, that's 757-683-8836. You can see previous editions of Health Watch online at www.norfolk.gov/Health Watch. You can also send me an email at terrence.affer-anderson@vdh.virginia.gov. Thank you so very much for watching Health Watch. Again, I'm Terrence Affer Anderson, and this has been Health Watch.